Okay, hello, Pharm Scholars. So, I am going to continue where I left off. I am in chapter 13. We left off on slide number 8, which starts insomnia. So, insomnia is the most common sleep disorder. It is usually mild and short lived. Common causes is lifestyle or environmental changes, which can include stress, because stress will also put you in a state of insomnia, pain, illness, anxiety, large amounts of caffeine, or larger meals before bedtime. So the three types of insomnia is initial. That's when someone has difficulty falling asleep. So initial insomnia is when someone has difficulty falling asleep. Intermittent is difficulty staying asleep. So the person can fall asleep, but they have trouble staying asleep. And then there's terminal. That's waking and an inability to fall back to sleep. So they get to sleep, but they wake up and then they can't get back to sleep. Up to 35% of adults experience insomnia in any given year. Insomnia is experienced by 95% of adults and of adults at some time. Some remedies people may use to counter anxiety and stress is caffeine, alcohol, drugs, and these can disrupt sleep patterns even more. Okay, moving on to slide 9. We're now going to talk about sedative and hypnotic therapy. So our hypnotics are drugs that produce sleep, and our sedatives are drugs that relax a patient but not necessarily put them to sleep. So there is a difference between the two. So again, your hypnotic is a drug that produces actual sleep, and your sedative is one that relaxes a patient, but they may not necessarily fall asleep. They may help increase total sleeping time, mainly in stages 2 and 4, because we talked about the stages just before we got cut off. Excuse me. They can decrease the number of REM cycles and amount of REM sleep. They may cause REM rebound when the drug is used or stopped. So I will get into rebound later, but so they can cause rebound when the drug is stopped. No single drug can produce all the desired effects of sedation and sleep induction without producing adverse effects. Most of these agents alter the sleep cycle in some manner and can be habit forming. REM sleep restores mental and psychological balance. If REM or dreaming is cut short, balance is not restored, and REM rebound may occur. So what is REM rebound sleep? It is when compensatory or reducing REM sleep. So basically, when your REM sleep is reduced, even when you're using hypnotic agents and they are only used for like 3 to 4 days. So basically, rebound is when you reduce the amount of REM sleep that you get in your cycle. So with your sedative hypnotic therapy, the actions of these meds is to sedate and produce relaxation and rest. Hypnotics produce sleep. So your sedatives produce relaxation and rest. Your hypnotics produce sleep. They should be used temporarily as a treatment for insomnia, or to decrease anxiety and increase relaxation and or sleep before diagnostic or operative procedures. And they can also be used as anticonvulsants or seizure meds. A single sedative, relaxation, and rest. A single sedative can produce different effects at different doses. A small dose acts as a sedative, A larger dose can act as a hypnotic. Patient condition, baseline level of consciousness, and age also contribute to overall effectiveness of this type of drug therapy. Okay. There's a question on slide 11. If you want to answer that, we can go over that Monday when we have our Q&A. So now I'm on slide 12. Nursing implications for sedative hypnotic therapy. Central nervous system function, vital signs, sleep patterns, anxiety level, environmental control, nutritional needs, alcohol intake, exercise, respiratory status. These are all implications when you're using sedatives and hypnotics. So basically what all those things are saying is your patient having any central nervous system issues? How's their vital signs? Is the medication working? What is their sleep patterns like? What's anything going on in their environment that might be contributing? Again, stress, caffeine, some things that they can somewhat control. What's their nutritional patterns or needs? Are they an alcohol drinker? Alcohol will contribute to your sleep cycles. Exercising and respiratory status. So assessing the CNS function, your central nervous system function overall. These meds depress the central nervous system or functions, and it is a key component of patient monitoring before and after any sedative or hypnotic agent is administered. You want to get a baseline level of consciousness and state of arousal should be recorded during assessment and then reevaluated. So basically what that's saying is you should be assessing your patients before and after treatment. Baseline sleep patterns may be difficult to measure in a healthcare setting because sleep patterns are usually disrupted by noise, interruptions, procedures, etc., etc. And this is elaborated a little bit more on page 194 in your textbook. Now I'm going to move on. We're still talking implications. So nursing, I'm on slide 13. I think that's 13. Yep, 13. Nursing implementation for sedative hypnotic. So we want to obtain vital signs periodically. Make sure that because your CNS is depressed, so that means there is a possibility blood pressure can drop, heart rate is going to drop, pulse is going to drop, so things like that. Give patient a pre-op medication at the specified time. So if the patient is getting these medications for a medical procedure or operation, they need to be given at the specific time that they are ordered for those procedures. Monitor the effects of the sedatives and hypnotics, and they may also be used as needed medications. So ask the patient about effectiveness of previously administered therapy. Sometimes it is necessary to repeat a medication if an order permits it to doing so. So some non-pharmacological interventions include offering dairy products, dimming the lights, reducing noise levels, increasing daytime activity so that you get, if you're doing more stuff during the day, you tend to be a little bit easier to come down at night and relax and fall off to sleep. So those are some of the implementations in regards to sedative and hypnotics. So for patient education in regard to sedatives and hypnotics, what's the patient's bedtime like? Are they doing okay nutritionally? Tell them to avoid heavy meals during the evening. Personal comfort. Can they get comfortable enough at night to kind of lull off and fall asleep? What's going on in their environment? Are they overwhelmed? Are they feeling stressful? Because those play a part into causing issues in the sleep cycle as well. Stress management. What's their activity and exercise level? Fostering health maintenance. Just having that self-care and trying to keep themselves in a good space. And also making sure that you do a patient self-assessment. Have the patient tell you how they feel things are going, and how they think the medications are working. Do they think they're effective? Do we need to look at dosage change? Do you want to try something else? And some of this information is compiled in your textbook on page 195. Slide 15 is a question. You're welcome to answer the questions, and we can go over those in class if you want. Slide 16 is a question. You're welcome to answer that, and we can go over that at the Q&A if you would like. Now I'm on slide 17. I'm still in chapter 13, and now we're going to talk about benzos. Remember the benzodiazepines. Benzodiazepines. I'll call them benzos, so I'm going to reference them as benzos. So these particular medications, they have what we call a wide safety margin. More than 2,000 derivatives exist. They're difficult to describe as a class, but they include your anticonvulsants, so those are your seizure meds, your anti-anxiety agents, so your meds for anxiety, and they include the sedative hypnotic agents. Benzos have an extremely successful extremely successful products for both the therapeutic and safety standpoint. So basically they're saying they've been therapeutic, so they help people a lot, and their overall safety stands out. Overdoses can be better tolerated and are not fatal. Although there are many derivatives in this class, only a small subset or a smaller portion of them is used clinically. And then you can read a little bit more about the benzodiazepines on page 196 in your text. So we're still talking about the benzodiazepines. So the actions of these particular medications is they affect your type 1 and type 2 GABA receptors. They bind to these receptors to stimulate the release of GABA. And I believe GABA was one of our neurotransmitters, remember? Because now the medications is sending the neurotransmitters is telling the nerves what the body needs to do based on the action of the med. So they are used preoperatively or for surgery as a sedative, and for conscious sedation. So say maybe you have an issue, like because it has an anti-anxiety property, you get anxious when you have to go to the dentist, and the dentist say, okay, I'm gonna prescribe you this one pill. I need you to take it 45 minutes before your appointment. That's conscious sedation. So you're taking it, but you're conscious, but it helps keep you in a calm state so that the procedure can be done. Common adverse effects is drowsiness, hangover feeling, sedation, lethargy, and decreased level of alertness. So let's say that dentist gave you that one benzo for a dental extensive dental procedure or something you had to have. These meds can decrease your level of alertness. So they may say, well, we will only do the procedure if somebody drives you. You won't be allowed to drive there, or drive home after the procedure, because they can affect your level of alertness. The serious adverse effects of benzos is confusion, agitation, amnesia, hepatotoxicity, and flumazenil is used for management of an intentional or accidental overdose of benzos. So this med is spelled FLUMAZ as in zebra, ENIL. This is the medication that is used to reverse a benzodiazepine overdose. Okay? For specific drug information, it is on table. It's in table 13.1 on page 197. And these are most commonly used sedative and hypnotics. Individual drugs in this class are prescribed for different uses, such as sleep and anxiety, based on their site of action within the central nervous system. When they are stopped, a rebound effect can occur. Let me say that again. When benzodiazepines are stopped, they have the potential to create what we call a rebound effect, causing rebound insomnia as well as bizarre dreams. So, if they think the benzos, this is what I'm saying is, if they think the benzodiazepines were working and then they stopped them or they were only prescribed for a certain amount of time, the patient can rebound back to having episodes of insomnia as well as bizarre dreams. Okay? That's what that's saying. Okay, now I'm on slide 19. This is nursing implications for the benzodiazepines. So you want to do a pre-medication assessment. So what that means is you want to chime in with your patient and assess them prior to giving them the medication. Availability, dosage, and administration. What's the criteria for pregnancy and lactation? Common adverse effects, again, neurologically, there can be drowsiness, hangover feeling, sedation, and lethargy. In the cardiovascular side, in common adverse effects, you might see hypotension when the patient gets up. So almost like a orthostatic hypotension, okay? The serious adverse effects psychologically is confusion, agitation, hallucinations, and amnesia. So they may not remember anything. Excessive use and abuse is an adverse effect and a serious adverse effect, and also blood disgracious. Routine lab studies should be run, meaning that it can cause different things going on in the blood system. Or hepatotoxicity. You might have some abnormal liver functions and tests. Refer to table 13.1 as needed for reference, and that's again is on page 197. Look at possible drug interactions with benzodiazepines. Routine lab studies indicate that red blood cell count and white blood cell count, differential and platelet count. So you want to do some, doctors should be doing some routine lab work with these as well, and should be doing some liver function tests. And that should include your bilirubin, your AST, your ALT, your gamma glucotransferase, the GGT, and your alkaline phosphate, and your increased, looking for increased prothrombin time. Okay, I'm going on to slide number 20. Okay, slide number 20. These are non-benzodiazepine sedative hypnotic agents. So they're sedative hypnotic agents, but they are not in the benzodiazepine class. These are non-benzodiazepine sedative hypnotic agents. So the action of these meds is varies effects on. They have various effects on the REM sleep cycle. They are used as sedative and hypnotic for the effects of like having sedative and hypnotic effects. Common adverse effects, again with the other ones: hangover, sedation, lethargy, decreased level of alertness, transient hypotension on arising. So that's almost like a hypoorthostatic, but from the sitting position. So if they get up too quickly, their blood pressure might drop. Restlessness and anxiety. For specific drugs in this class, see table 13.2. It's on page 199. Most recommended only for these meds, so non-benzodiazepines are only recommended for short-term use of like 7 to 10 days or for as long as 3 weeks with good evaluation. All cause CNS depression, but mechanism of the action may differ. Okay? So now I'm going to move on to slide 21. We're talking about now nursing implications for non-benzodiazepine sedative hypnotic agents. Again, you want to do a pre-medication assessment. What's the status of your patient prior to them starting or giving that medication? Is it available, the dosage and the administration, all that information correct? Common adverse effects, again, neurologically, it's the hangover feeling, sedation, and lethargy. For cardiovascular, it's that transient hypotension when arising. Psychologically, it's restlessness and anxiety. Drug interactions, with your non-benzodiazepines is Luvox, Luvox, and that's usually prescribed for OCD, and Rifadin, and that's prescribed for TB, and maybe some foods. Check page 201, and some of this information should be contained there. Okay. Slide number 22 is a question. You are welcome to answer that. We can go over that in class. And that concludes the chapter 13, drugs used for sleep. I will be doing all the chapters separately in case you need to watch the video separately so that all this stuff doesn't run in back to back. So that was the conclusion of chapter 13 when we left off yesterday at lab. All right, ladies, have a good one. I'll be getting chapter 14 going in just a little bit.